Today, we're tackling something really important for anyone managing ACS patients, the brand new 2025 ACCA's and Multi-Society Guideline for Acute Coronary Syndromes.
Synthesizes a ton of recent evidence. Our
Mhm.
goal today is really just to hit the highlights, the most impactful updates you need to know for your practice.
This guideline pulls together a lot, doesn't it? It replaces that 2016 DAPT-focused update.
Exactly, and it incorporates evidence from, I think, 3 other recent guidelines, plus the big 2021 coronary artery revascularization guideline, so it's pretty comprehensive.
So we're going to try and focus on what's really changed, what might shift how you actually treat patients day to day.
And a good way to do that, I think, is to look at the top take-home messages the guideline authors themselves pointed out. They specifically highlighted numbers 2, 3, and 6 as, addressing known gaps or incorporating really strong new data.
Okay, that makes sense. Before we jump into message number 2, though, just a quick plug. If you find this kind of evidence breakdown useful, you should definitely check out a podcast called Evidence-Based Cardiology Talks. It's specifically for cardiologists, digging into new journal publications, keeping you right up to date. It's on Spotify, YouTube, all the usual places.
Definitely worth subscribing.
And just for context, is under the supervision of Dr. Caroli. You can find him at drcaroli.com. Okay, let's do it. Take home message 2. Dual antiplatelet therapy, DAPT, always a hot topic.
Always. So the baseline is still pretty familiar. DIPT aspirin plus an oral P2Y12 inhibitor is the default for at least 12 months for ACS patients, assuming they're not at high bleeding risk.
12 months standard duration. But the choice of P2Y12 inhibitor, especially after PCI, there's a stronger steer now, isn't there?
There really is. The guideline gives a clear preference for ticagrelor or prasugrel over clopidogrel in ACS patients who undergo PCI.
And the rationale is stronger evidence for reducing ischemic events.
Exactly. The data supports a greater reduction in things like MI or stent thrombosis with ticagrelor or prasugrel in that setting.
Okay, what about upstream therapy? For NSTE, ACS patients waiting for their path, maybe more than a day.
That's addressed too. If angiography is planned, but it's going to be more than 24 hours away, the guideline says you may consider upstream clopidogrel or ticagrelor.
May consider. So not a strong recommendation, but an option.
Right. It's a Class 2B recommendation. There's potential benefit, but it's not as definitive, and you always weigh the bleeding risk.
Which brings us to bleeding risk. That's the constant balancing act with DAPT. What strategies does the guideline emphasize to mitigate bleeding, especially around PCI?
Several key points here. First, pretty straightforward, use a proton pump inhibitor, a PPI, for patients who are at risk of GI bleeding. That's a Class 1 recommendation.
Makes sense. Protect the gut. What about the DAPT duration or strategy itself to lower bleeding risk long-term?
This is where we see some interesting evolution. For patients on DAPT with ticagrelor, if they've done well for the first month post-PCI without major bleeding,
Yeah.
the guideline now recommends considering a transition to ticagrelor monotherapy at or after 1 month. So, dropping the aspirin.
Well, that's quite a shift from the traditional 12 months of DAPT for everyone, aimed at reducing late bleeding.
Precisely. It's based on trials suggesting that after that initial high-risk period, ticagrelor alone might offer a better balance of ischemic protection and bleeding risk for some patients.
Interesting. And what about the really tricky situation, patients needing long-term anticoagulation plus antiplatelets after PCI? Triple therapy risk is high.
Super high risk.
Yeah.
And the guideline pushes for minimizing triple therapy duration. The recommendation is now to discontinue aspirin, usually between 1 and 4 weeks after PCI.
Just 1 to 4 weeks of triple therapy?
Yeah, then continue with the oral anticoagulant plus 1 P2Y12 inhibitor. And in this specific scenario, clopidogrel is often preferred because it's thought to have maybe a slightly lower bleeding risk when combined with an anticoagulant compared to ticagrelor or prasugrel.
So really tailoring the antiplatelet strategy based on bleeding risk and concomitant therapies. Much more nuanced.
Definitely more nuanced than a one-size-fits-all 12 months of DAPT.
Okay, let's switch gears. Take-home message number 3. Lipid lowering. This feels like another area where the guidelines are getting even more aggressive.
Oh, absolutely. The message is loud and clear. High-intensity statin therapy for all ACS patients. Full stop.
Start high intensity right away.
Right away. And interestingly, the guideline even says you can consider initiating ezetimibe concurrently with the high-intensity statin from the outset.
So potentially starting combination therapy immediately in everyone, or just considering it.
It says option to initiate, so it's not mandatory for all, but it reflects the push for getting that LDL cholesterol down fast and effectively right from the beginning, really hitting the ground running.
And what if, despite the maximally tolerated statin, the LDL is still not low enough? What's the threshold now?
The key threshold mentioned is an LDL-C remaining at or above 70 mg/dL, which is 1.8 millimole.
So if LDL is 70 or higher on max statin,
Then the recommendation is class 1, you should add a non-statin agent.
and the options listed are,
Ezetimibe is the first go-to, often, but also the PCSK9 inhibitors, evolocumab and alirocumab, are options, and they also explicitly mention inclisiran and bempedoic acid.
so a broader range of non-statin options formally recommended now.
Yes, reflecting the newer agents available and the strong evidence for additional LDL lowering beyond statins in this very high-risk group.
Is there guidance even below 70? What if someone's, say, 65 mg/dL on their max statin dose?
Yes, there's nuance there too. The guideline says it's reasonable that's a Class 2A recommendation to further intensify lipid-lowering therapy if the LDL-C is between 55 and just under 70 mg/dL.
So aiming even lower towards that 55 mark is considered reasonable for these ACS patients.
Exactly. The thinking is that for this ultra-high-risk population, achieving even lower LDL levels likely provides further benefit.
How does this compare briefly to the European ESC guidelines from 2023? Are we generally aligned on lipids?
Broadly, yes. Both sides of the Atlantic are pushing for very low LDL targets after ECS, generally below 55 mg/dL. The ESC often emphasizes a sequence max statin, then add ezetimibe, then consider PCSK9 inhibitor.
Right.
The new ACHA guideline, by mentioning concurrent ezetimibe as an option and listing all the non-statins together, might seem slightly different in approach, but the end goal, aggressive LDL reduction using combination therapy when needed, is very much shared.
Okay, clear message. Be aggressive with lipid lowering early, use combination therapy when needed to get below 70, and even consider pushing towards 55. Let's move to take-home message 6. Revascularization strategy. Big focus on complete revascularization.
Yes, that's a major theme. For patients with multivessel disease, whether it's STEMI or NSTE-ACS, the general recommendation is now to aim for complete revascularization.
Meaning fix more than just the culprit lesion.
Exactly. Addressing significant stenosis in non-culprit arteries as well, with the goal of improving long-term outcomes, reducing death, MI, and angina.
Okay, let's break that down. For STEMI patients with multivessel disease, once you've fixed the infarct artery, what about the others?
So in hemodynamically stable STEMI patients, after successful PCI of the infarct-related artery, the guideline recommends PCI of significantly stenosed non-infarct-related arteries.
When should that happen? During the same procedure? Later?
It can be done either at the index procedure or as a planned staged procedure later during the same hospitalization or soon after. The guideline actually suggests a slight preference for doing it all in one go if it's low-complexity disease and the patient isn't intended for CIBG anyway.
Okay. Preference for single stage, if feasible, and low complexity and stable STEMI. What about stable NSTE-ACS patients with multivessel disease who are getting PCI?
Similar principle. If they have multivessel disease and aren't headed for CIBG and don't have significant left main disease, after the culprit lesion PCI, it's recommended to also perform PCI on significant non-culprit lesions.
Again, index procedure or staged.
Either is acceptable according to the guideline. The key is the strategy of completing the revascularization to reduce ME down the road.
So a strong push towards complete revascularization in most stable ACS patients with multivessel disease. But there must be exceptions. Cardiogenic shock comes to mind.
Absolutely critical exception. The guideline is very clear. Routine PCI of non-infarct-related arteries should not be performed in STEMI patients with cardiogenic shock.
Too risky.
Yes. Studies have shown it can increase the risk of death and renal failure in that incredibly vulnerable state. The focus has to be on stabilizing the patient and opening the culprit artery.
And does that apply to NSTE-ACS with shock too?
Yes, same principle. Routine PCI of non-culprit arteries is also not recommended in NSTE-ACS patients presenting with cardiogenic shock. Stabilize first, address the culprit, deal with other lesions later if the patient recovers.
Okay, that's a vital safety point. So those were the 3 big take-home messages the authors highlighted. Are there any other key recommendations sprinkled throughout the guideline that are worth a quick mention?
Yeah, a few quick hits. Reinforcement of radial access being preferred over femoral for PCI. Less bleeding, fewer vascular complications. That's pretty standard now, but good to see it emphasized.
Okay, radial first. Anything else?
Use of intracoronary imaging, IVUS or OCT, is recommended to guide PCI, especially in complex lesions, to optimize stent results.
Makes sense. See what you're doing. What about mechanical support in shock?
They touch on microaxial flow pumps, like Impella, They say use may be considered in selected cardiogenic shock patients, as it might reduce mortality, but
But
it comes with higher risks of complications like bleeding or limb ischemia. So it's a very careful selection process and not a routine recommendation.
got it. High risk, potential benefit in select cases. Anything on transfusion thresholds?
Just a brief mention that in anemic ACS patients who aren't actively bleeding, transfusing to maintain a hemoglobin of 10 GDL may be reasonable. Not a strong recommendation, but allows for it.
And finally, the importance of what happens after discharge, secondary prevention.
Absolutely paramount, as always. The guideline stresses checking a fasting lipid panel for 8 weeks after starting or changing lipid meds to see if you're hitting those targets.
Right, follow-up is key.
And crucially, referral to cardiac rehabilitation. They specifically mention that home-based cardiac rehab programs are effective options too, which increases accessibility. Strong recommendation for rehab.
Excellent. So this has been really useful getting a handle on the major shifts in the 2025 ACS guidelines. DAPT is more tailored, lipids are more aggressive, and revascularization is more complete. We really encourage everyone listening to dive into the full guideline document itself. And don't forget, for ongoing updates, subscribe to Evidence-Based Cardiology Talks on Spotify and YouTube.
My pleasure. Lots to think about.